So a little bit of an introduction to Dr. Salbach. She is a physical therapist, associate professor, and Heart and Stroke Foundation mid-career investigator in the Department of Physical Therapy at the University of Toronto. She's published more than 80 research articles and obtained over $6 million in funding. Dr. Salbach's knowledge translation research has focused on exploring the influence of facilitation and guideline implementation tools on advancing stroke rehabilitation practice and the implementation of task-oriented community exercise programs for older adults with balance and mobility limitations. Dr. Salbach has expertise with cluster randomized trials, process evaluations, systematic and scoping reviews, measurement, and multi-level modeling. She co-chairs the writing group to update the Canadian Stroke Best Practice Recommendations. So I am happy to pass the floor over to Dr. Salbach.
Great. Thanks so much, Megan, and thank you to KT Canada for the invitation to be part of their seminar series. And thanks to everybody who has linked in. So today we'd like to discuss the role of toolkits, as Megan has indicated with the title. And if you're interested to actually view the smartphone app that we developed as part of this toolkit, then you feel free to go to our website, which is at www.iwalkassess.com. And when you click on Get the Free App, you'll be able to download the app to your Android or Apple phone so that you can see some of the work that we've done. So the app is free. Our learning objectives for today are to describe the development of a theory-based toolkit that we designed to facilitate the adoption of a new approach. It was an evidence-informed approach to evaluating walking post-stroke targeted at physical therapists. Today we'll also summarize the results of a multi-site uncontrolled mixed methods study that we conducted that examined practice change among physical therapists after we provided them with this toolkit. And then finally, to discuss the implication of findings for implementation science in the context of stroke rehabilitation. As you may know, there are approximately 400,000 Canadians currently living with the effects of stroke. And studies by Kruger and colleagues have shown that the prevalence of stroke will increase to over 650,000 by 2038. Rehabilitation starts in the acute care setting after people become medically stable. Because of sensory motor deficits that result from stroke, more than 50% of people experience difficulty walking. After people become medically stable in acute care, physical therapists do begin the rehabilitation process to address mobility and walking limitations. And approximately 1/3 of people admitted to acute care hospitals will continue their rehabilitation in inpatient rehabilitation hospitals and then in outpatient settings before they are discharged from health services. So in rehabilitation, patients have identified, of course, walking recovery as a primary goal in stroke rehabilitation, making it a focus of what we do in physical therapy practice. We do have extensive clinical practice guidelines for stroke rehabilitation in Canada, and at the time of this study, 3 of the clinical practice recommendations in our guideline that were of note were that assessments of walking should be conducted using standardized valid assessment tools, and these tools should be adapted for use in patients who have communication limitations such as aphasia, which is quite common post-stroke. Another recommendation was that we should be providing patients, families, and caregivers with education about the rehabilitation process, and that patients and families should be involved in their own management, specifically with goal setting and transition planning. So the way that I framed this project was that we had these best practice recommendations, and I wanted to develop the resources that would help to facilitate their implementation. Because we knew at this time that there were 2 particular walking tests that were highly recommended for use in stroke rehabilitation in the acute care, inpatient rehabilitation, and outpatient settings. And these are the 10-meter walk test and the 6-minute walk test. These walk tests were recommended at the time in Canadian, American, and Dutch guidelines. For those of you who are unfamiliar with these tests, the 10-meter walk test is used to measure walking speed, and the 6-minute walk test is used to measure the maximum distance a patient can walk in 6 minutes. And this is by walking back and forth along a straight 30-meter walkway. The reason why these two tests in particular were recommended for use post-stroke is because many studies had indicated they have high reliability. As well, an extensive number of randomized controlled trials had used both of these tests and shown that they are responsive to change following use of a number of modalities to improve walking ability post-stroke. They're also simple, they're quick to administer, and they're inexpensive tests. They really just require some tape and a measuring tape and a stopwatch. And there has also been extensive research that has shown that both of these tests, which capture walking speed and walking distance, are relevant to how people might walk in the community and relate to their ability to complete their activities of daily living. However, our early research had shown that there was a knowledge to practice gap. A survey of 270 physical therapists involved in neurorehabilitation showed that fewer than 50% used any standardized measure to evaluate or monitor change in walking ability. In terms of these two specific tests that are the focus of this presentation today, in the study, overall only 15% used the 10-meter walk test and only 11% used the 6-minute walk test. And you can see by the table on this graph that there were the lowest rates of use in the acute care setting and that higher rates of use were observed in the rehabilitation and private practice settings of the 270 physical therapists that we surveyed. In my research, I do use the knowledge to action framework as an overarching framework to guide the steps of my knowledge translation research. And Katie Sibley and I have an article in the journal Physical Therapy that describes how we used this and other theoretical frameworks to understand balance and walking practice in rehabilitation and how knowledge translation interventions might be used to address the suboptimal practices in terms of evaluation. So using this framework, we had identified the knowledge to practice gap, and also we had used the framework to search the literature for the particular knowledge and research evidence as it was available to guide our clinical practices. And my next steps were to look to the literature and also conduct my own research to assess barriers and facilitators to knowledge use, and then to select and tailor and implement interventions that would address these barriers and incorporate the facilitators. And then finally, the study I'm going to tell you about today was also designed to monitor knowledge use. And so really this part of the knowledge to action framework was what was used as a basis for the study I'm going to tell you about today. In addition, sorry, my slide's not advancing. There we go. So in addition, I also use self-efficacy theory to guide this work. And self-efficacy theory is a theory that provides or describes 4 theoretical mechanisms for improving an individual's self-efficacy to perform a particular behavior. Self-efficacy beliefs are generally operationalized as your confidence in your ability to perform a particular task or activity, and your self-efficacy beliefs are seen to predict your behavior or your implementation of those tasks. And the 4 ways that you can boost an individual's self-efficacy include performance accomplishments, where if you experience success in performing the task at hand, then that will boost your personal self-efficacy to do the task. Vicarious experience was also relevant to this work, given that we know physical therapists often consult with their peers and often work with other physical therapists. So if they observe their colleagues experiencing success with a new practice, then that is expected to boost their personal self-efficacy. And then verbal persuasion relates to a more senior peer or someone who's considered to be an expert providing positive feedback in your ability to do the new task. And emotional arousal relates to how you feel in performing the new practice and whether you feel comfortable. So if you do feel comfortable, then that is expected to boost your self-efficacy. So self-efficacy theory was really key in this research to setting up, to informing our interventions and to make sure that our interventions included practice and observation of peers. In 2011, Anna Gagliardi and colleagues produced an article that described a conceptual framework that was an implementability framework, and this framework was designed to improve the implementability of clinical practice guidelines. And I was really excited when I read about this work because I had this idea that as in rehabilitation practice that we could be doing better in implementing our guidelines, and this framework reviewed different domains that would help to guide how we might improve how we implement our guidelines. So it started to give me the idea that maybe I could develop a resource that would complement our clinical practice guideline, that if it had these domains, if it addressed these domains, then it would be effective in facilitating practice change. So one particular part of the one domain that is particularly relevant, for example, is applicability. So was information in your resource provided by which to interpret and apply the guidelines for individual patients? So in terms of using these walk tests, that would guide me to make sure that in the intervention that I provide information that can help physical therapists to interpret and apply walk test performance in their clinical practice for individual patients. I also conducted my own research and looked to the research of others to identify barriers and facilitators to knowledge use. And the barriers to walk test use that have been reported relate to characteristics of the provider. So in terms of the first couple of rows on this table, the barriers relate to really the physical therapist level of knowledge and the fact that it's diminished in terms of their knowledge of walk tests, and also they report having decreased skill and self-efficacy to administer these walk tests. And then further, there's also barriers related to their personal time to review the research literature to actually know what is available. And they also have a diminished belief that walk tests will be applicable to their stroke population, because these two walk tests, some therapists believe that patients need to be able to walk independently to perform these walk tests. And so a lot of patients who are admitted to stroke rehabilitation are not able to walk on their own. And so as a result, physical therapists may believe that these walk tests are not applicable to their clinical practice. Also, it's well known that there may be barriers that relate to the actual practice itself. So in terms of these two walk tests, they do take time to administer and extra time to score and interpret. And in some cases, there's also barriers related to the practice setting, where there may not be, for example, a 30-meter section of the hallway where physical therapists could conduct the 6-minute walk test, for example. There are also barriers that relate to the patient. So in terms of patients with impaired cognition or communication, if the walk tests have not been adapted for them, then they're difficult to use in clinical practice. And further, if they need assistance to walk, then it makes doing the walk test more difficult. And then finally, there are barriers related to the research, wherein there are actually numerous protocols for administering these two tests and extensive number of studies published on reference values for these tests. The literature also does describe some facilitators to the use of walk tests, and these include being familiar with them, used by experienced therapists in your practice setting, the fact that they're recommended in guidelines, evidence of validity and reliability, that the measure be easy to use and quick to administer, and also that patients who are at a higher level of functioning are easier to administer these tests with. At the time of developing the intervention to address these issues, there was little direction from, I guess, knowledge translation studies in terms of what was the best way forward. So systematic reviews showed that the effectiveness of the strategies evaluated was unclear, and that there was low methodological quality across the studies, and there was also little use of behavior change theory to show how it could be used to underpin the interventions in order to achieve greater practice change. And as well, behavior change was sometimes measured using self-report, which is vulnerable to social desirability bias, and a plethora of interventions were used. So as you can imagine, and it's no surprise that no one intervention was appropriate, and so a number of strategies were used in the literature, and it was difficult to figure out from this literature what should be the best intervention for administering or for addressing the problem of inconsistent use of these two walk tests. More recently, there have been systematic reviews and scoping reviews. There's two of them in particular of the effectiveness of toolkits, and this literature was just being published after this study was begun. So basically a toolkit was defined by Yamada and colleagues as a packaged grouping of multiple KT tools and strategies that codify explicit knowledge and are used to educate and or facilitate behavior change. And in this particular systematic review, there were 39 studies that evaluated toolkits, and the quality evaluation of these studies showed that there were only 13 that the authors rated as moderate to strong. So across the 39 studies, more than 51% were developed for a specific disease context, but these were primarily in cancer and diabetes, so none of these toolkits had been developed targeting stroke. 3/4 of the studies had developed toolkits targeting healthcare professionals, and again, mainly physicians and nurses, so not rehabilitation professionals, so there wasn't as much guidance for the rehabilitation context. Also, the single component toolkits consisted primarily of educational materials. The multi-component toolkits consistently included educational materials, but then added on other resources such as templates, visual reminders, electronic tools, and pocket cards. And the authors concluded that future toolkits should be informed by high-quality evidence and theory, and should be evaluated using rigorous study designs that can help to explain the factors underlying their effectiveness and their successful implementation. Other research that guided my work was research I had done exploring what physical therapists thought about the use of personal digital assistants, and this just shows how long a way we've come. So PDAs is what we called them before they became smartphones. So basically the use of a smartphone application in clinical practice. And physical therapists in our qualitative research had reported that they thought that using a personal digital assistant would enable a quick and timely access to information in daily clinical practice, and that it would facilitate sharing information with colleagues and research evidence. But the disadvantages were that there would be a need for training, and also they were worried about using their smartphones in front of patients. Some therapists talked about how the small size of a smartphone might limit their ability to view it quickly, view the information quickly, and also the high cost of the device. And of course, smartphones have come down in price, and also the difficulty of wearing the device, like where would they put it in terms of during their clinical practice. So with all of this information at hand, I thought to address the first challenge, which was to develop and evaluate the validity, implementability, and readability of a theory-informed guide that was designed to facilitate physical therapist application of a new evidence-formed approach to using the 10-meter walk test and the 6-minute walk test post-stroke in acute care, inpatient, and outpatient rehabilitation settings. So this first step was really about developing what I would later call the iWalk Toolkit. The way I initially conceptualized it was based on Gagliardi and colleagues' implementability framework, my first thought was that I was going to develop a guide that would help us to implement these 2 walk tests and that would incorporate the theory of implementability as well as self-efficacy theory using the knowledge to action process as an overarching framework, and that I would use this guide to help promote the use of the practice that I was developing. So in terms of our steps, just to give you an overview, we started off by first developing what this new practice was, because we weren't simply telling therapists that they should just do these tests. You know, we had to say how these tests should be used in clinical practice. So we conducted 4 systematic reviews of the literature, and we adapted a single protocol for using the 10-meter walk test that was for people with stroke, and a single protocol for the 6-minute walk test, again, that was stroke-specific. And we also developed an approach as to how you would interpret performance in clinical practice, because these were considered facilitating factors. And then we developed an educational guide that targeted the barriers and was informed by the self-efficacy theory and the guideline implementability framework that Gagliardi and colleagues had proposed. And then we had the guide reviewed by 10 international experts who were researchers and 18 end users. So in knowledge translation terminology, we say end users are the people who will ultimately use your resource. So we asked 18 Canadian physical therapists who practiced in acute care, inpatient rehabilitation, and outpatient settings, as well as home care settings, and we asked them to evaluate the guide. Then we finalized the guide content, and then we basically took the content and used it to finalize the development of a smartphone app and a video. And these 2 additional components within Gagliardi's guideline implementability framework were really, the strategy was that we were duplicating content that was in the guide in other formats, so in the form of an app and in the form of a video, and such that they would reinforce each other. Because the guide was really seen as being an educational resource that would be used during learning sessions, but the smartphone app was something we wanted people to use in actual clinical practice. Then we beta tested the app with 3 physical therapists and did final toolkit revisions and app revisions based on everyone's feedback. And lo and behold, we came up with the Walk Toolkit. And so even though in the beginning, I actually didn't think of it as a toolkit, but then I began to call it a toolkit because this is now the way it's easy to view, like basically a clustering of KT strategies that you are putting forward as an intervention to help facilitate practice change. And so the toolkit had 3 components: the iWalk guide, the iWalk Assess app, and the iWalk video. And if you're interested in viewing these resources, if you go to www.iwalkassess.com, there are links to both the guide and the video there if you're interested to view them. So now I'm going to tell you about how we designed these resources in order to address barriers to clinical practice. So the iWalk guide had 7 modules, and there were 3 modules here: performing the tests, interpreting test performance, and educating and setting goals, which, as the module titles tell you, related to the practices we wanted to promote. So we wanted therapists to perform the tests, we wanted them to interpret the tests, and use the results to educate patients and their colleagues and set goals with their patients. We also had a module that identified efficacious walking treatments that the 10-meter walk test and 6-minute walk tests were known to respond to. And so this was a fairly short module, and these were treatments that had level A evidence that were in our clinical practice guideline for stroke. We also had a module that incorporated a process for audit and feedback. And for this module, it was targeted at professional leaders who might have the time to perform audit and feedback with their clinicians as a way to provide feedback about how they were doing with intended practice change. And then we had a module which involved, Module 7, was putting it all together with case scenarios. We provided this in order to provide case scenarios as a basis for learning sessions because the iWalk appendix involved contained agendas for 3 learning sessions that we wanted the hospital sites to conduct in order to provide an opportunity within a group to sit down and to practice the walk test, to discuss the walk tests, and how they would move forward to implement them in clinical practice. In the iWalk guide, we also had specific sections or strategies that were designed to address this barrier about whether the walk tests were considered by therapists to be relevant to their clinical practice. So one of the strategies was that we developed a list of the top 10 reasons to use the 10-meter and 6-minute walk tests. And these top 10 reasons incorporated the research evidence, and it talked about the reliability and validity of the walk tests, and really incorporated the facilitators that we had found in our literature reviews, facilitators to practice change. Further, we introduced what we called iWalk recommendations, which were very straightforward statements about how we expected therapists to use the tests. So you can see on the slide, one of the first things was we wanted them to administer the tests, and we described in whom, and then that we also wanted them to re-administer the tests to look at practice change. And finally, we indicated the Canadian Stroke Best Practice Recommendations, which were, in other words, the clinical practice guidelines, that this toolkit was designed to support. And so this was, again, designed to increase the perceived relevance of using these tests in clinical practice. We also included in the guide easy, very straightforward diagrams that would facilitate the physical therapist setting up the walkways for using the test. And for those of you who are not familiar, so to conduct the 10-meter walk test, the patient is asked to walk along a 14-meter walkway, and the therapist times the middle 10 meters and uses that time in seconds to compute walking speed. The 6-minute walk test is recommended to be done on a 30-meter walkway, and the patient walks back and forth along this 30-meter walkway, and the distance walked in 6 minutes in meters is documented. In the guide, in one of the modules, we also showed the therapists how they could interpret the values on the test, and this can really apply to any assessment tool that we use in healthcare practice. So in this case, because the 10-meter walk test evaluates walking speed, we provided age and sex-specific normative values from the literature. And again, part of our systematic review was we had to drill down, well, to which study, which normative values were we going to use? So instead of having the therapist figure that out, we used our research team's expertise, and we used criteria to select out those normative values. And then we also provided a way to compare walking speed to classify patients as either household or limited or community ambulators. We also talked about measurement error by referring to minimal clinically important differences and minimal detectable change, which is defined in clinical practice as the change that your patients have to make to get beyond measurement error. We provided similar information for the 6-minute walk test, which is shown on this slide, and different information in this first table here shows you results from studies where they actually took a meter wheel out into the community to figure out what was the distance that was needed to walk at different community settings. And it's no surprise that at superstores or club warehouses like Costco in Canada, that the distance to walk through about half of the facility was approximately 680 meters, so a very extensive distance if you want to go shopping in these types of facilities. As part of the guide, we also had these 3 learning sessions, which we expected our therapists to hold. And for those of you who are maybe not familiar, but at least in Ontario, Canada, hospitals will often have a clinical practice or a professional practice leader who is, part of their time is devoted towards facilitating best practices. And so we felt that such a leader could help to facilitate these learning sessions because we provided all of the tools to conduct them. So in the first session, the activities included reviewing the video, practicing the tests, and discussing their implementation. And then we asked them as homework to actually use the test with one patient before they came back to the second learning session. In the second learning session, they had practice entering data into the smartphone app and to interpret performance and and then also they could complete forms that we appended to the guide. And again, they were supposed to go back and practice with a patient and before they came back to session 3. And session 3 involved role play, which the therapist did not like very much, but it was role play to actually practice goal setting with patients and to discuss the findings from audit and feedback. So this slide is just to show you that this video we developed was actually educational. It had educational content. It wasn't just a demonstration video. It had text in it to provide specific information on guiding therapists and how to do the tests. And so it was really a briefer complementary resource that was designed to increase their knowledge and self-efficacy to do the tests because it showed a physical therapist demonstrating the test with a patient with stroke. The app included timing tools for conducting the test that made it easier to do the test in clinical practice. And as well, it provided automatic calculations so the therapist did not have to take out their calculator. So it automatically calculates walking speed for you, and it provides the interpretation in terms of community ambulation and the normative values, and it compares the person's walking speed to the speeds you need to cross the street, and provides a bar graph that you can use to share with your patients to facilitate education. And this really was done as a way to reinforce the applicability of the toolkit, for example, according to the guideline implementability framework. And then further, the provision of these agendas for the 3 learning sessions was how we operationalized the implementation domain of the guideline implementability framework. And then when we sent out our guide, our IWalk guide for review with these 10 academic experts across the world, we asked them to actually rate the guide across these implementability domains. And on a scale from 1 to 5, where 1 is poor and 5 is excellent, you can see that the average ratings were quite high across all of the guideline implementability domains. The 18 physical therapists who evaluated the guide evaluated different aspects. They evaluated format, organization, readability, and content validity, and they rated the guide highly. In terms of feasibility to do the walk tests, they rated the feasibility of doing them in the acute care setting as just average. And then in inpatient rehab and outpatient, they felt these walk tests would be more feasible and less feasible again in the home care setting due to lack of space. So this first phase of the study showed us that we felt we'd produced a guide that was valid, readable, and implementable, that feasibility might be a little less in acute care than in inpatient, outpatient settings. The app was considered an acceptable prototype after it was beta tested, and that we were ready to evaluate the toolkit in acute care, inpatient, and outpatient settings. And this was the objective of the second phase of our study. In this second phase, we conducted a mixed methods uncontrolled intervention study that involved 49 physical therapists from 9 hospitals in Ontario and Nova Scotia. We supplied them with a toolkit in September of 2015, and then we collected various data from them pre and post using online surveys. We looked at how their practice changed using a chart review of all people admitted with stroke 8 months prior to and 8 months after the 5-month intervention phase. We also did a qualitative process evaluation by interviewing professional leaders and conducting focus groups with physical therapists at each site. And this was the way we conceptualized our process evaluation. So we looked at how much they engaged with the learning sessions and with reviewing the guide. We looked at their ratings of self-efficacy to perform the practices pre and post. And we did a realist analysis of the qualitative data to look at their various experiences implementing the toolkit. And in terms of quantitative outcomes, the chart review gave us data that allowed us to look at pre and post, the extent to which their documented administration of the walk test changed pre and post among patients with stroke. This slide shows you that in the 43 participants on whom we had data from the chart review, out of the 49 who participated, that the average age of the therapist was 30 to 39, that we had a high percentage that were female because this is really characteristic of physical therapy practice. The majority of therapists held a bachelor degree, and we really had a lot of good spread in terms of the years of clinical practice. Interestingly, and what favorably, we had about a fifth of therapists that worked in the outpatient setting, and interestingly, 77% told us they'd already learned the 6-minute walk test during their professional program, but many fewer, more about 1/4 had learned to use the 6-minute walk test. And in terms of who participated in the focus groups, we had similar characteristics. This slide shows you how much sites engaged in the 3 learning sessions that we promoted. All sites completed learning sessions. 2 sites reviewed the content in fewer sessions, and therapists who could not attend the learning sessions did report reviewing the guide on their own. So we had the lowest attendance at the 3rd session, but thankfully this was related to practices that many therapists have experience conducting. This slide shows you that most participants reviewed the guide modules and the video, and that 3/4 of them practiced the 10-meter walk test, and about half of them practiced the 6-minute walk test. And 85% of them reported using the iWalk Assess app between 1 and 5 months. So I was very glad to see that because we had specifically designed the learning sessions to promote improvements in self-efficacy, that the analysis of self-efficacy ratings showed that there were significant improvements in self-efficacy to do the recommended 10-meter walk test practices pre to post. And these practices related to not just administering the tests, but also interpreting test performance, educating patients about test performance, setting goals, and applying treatments known to improve test performance. However, self-efficacy ratings did not significantly improve for 6-minute walk test practices. There were small improvements observed, but non-significant, and this may be because therapists started at a very high level at baseline in terms of their ratings on a scale from 0 to 100. Our chart review results showed exciting findings. So I'll just go back to this slide. We had data from 348 health records at baseline and from 375 health records post-intervention. And pre and post, the characteristics of the people with stroke were similar. And I want to just clarify that these were people with stroke who were able to stand and walk with assistance. So we selected the charts of people on whom the walk test would be applicable. And what you can see from this slide is, as expected, these people with stroke were on average this is actually the median age of 73. We had some good spread across the 3 settings. The majority of people had suffered an ischemic stroke, and there were individuals with aphasia and cognitive impairment, and there was also a spread in terms of the number who required no assistance versus assistance to walk. Now, what this table shows you is the percentage of hospital visits for which the walk test was documented at least once. So what it shows here in yellow for the 10-meter walk test is that across acute care, inpatient rehab, and outpatient rehab settings, that this is the percentage of patients in whom the 10-meter walk test was done at least once. So very low percentages here, and they did improve, and the improvements were greatest in inpatient and outpatient rehabilitation. For the 6-minute walk test, the baseline performance of this test was somewhat higher, but not in acute care, and there were similar improvements observed. And so it won't surprise you then that in our random effects logistic regression module, that across settings, when we pooled the data, that there were significant improvements in the percentage of patients, or in the odds of a therapist performing the test, the 10-meter walk test and the 6-minute walk test. And this was even after adjusting for clustering at the provider level and at the hospital setting level, and also for the ambulation ability of the patients and presence of aphasia and cognitive impairment. In our qualitative results, these were very interesting. We conducted a focus group at each of the sites and interviews with people in leadership positions in 8 out of the 9 sites. At one of the sites, the professional practice leader went on leave and was not available and was not there during the intervention phase. And what our realist analysis showed us was that when we synthesized the stories about what happened across the acute care sites and what happened across the inpatient and outpatient sites, we found 4 what we called like unique stories or context mechanism outcomes from our study. In the acute care setting, there were 2 unique stories. The acute care setting was characterized by having a lack of space for these walk tests, a lot of hallway traffic, low patient tolerance, the majority of patients were not ambulatory, brief hospital stays, and therapy goals that related to basic mobility. And one of the stories in acute care sites was that the professional leader was off-site or not available, and that the physical therapist worked in different units across the hospital and treated patients with stroke infrequently. The physical therapists in this kind of scenario were not able to mark walkways for the test. They had difficulty managing the learning sessions because of the lack of the involvement of a professional leader. They did not they reported they did not practice the tests, and they described the tests as irrelevant to their clientele, and they lacked motivation to integrate the test clinically as a result. And so the walk tests in this scenario were not used during the study, and the therapist had no intentions to use them in future. The second scenario in acute care was that there was a professional leader on site, and that physical therapists were familiar with one or both walk tests. The professional leaders marked permanent walkways near stroke units and participated in learning sessions with the physical therapist. The therapist used the app to practice walk tests, and they used reference values with the patients and observed a benefit to patients. These therapists used walk tests on high-functioning patients during the study, and they did have intentions to continue this practice in future in these high-functioning patients. In terms of the inpatient and outpatient setting, there were 2 scenarios. One was that the professional leader was replaced, and the site had a lot of human resource challenges during the study. Physical therapists worked in different units, and inpatient stays were becoming shorter with heavy caseloads. The professional leaders described a lack of social influence, but physical therapists did engage with the guide and with learning sessions, even when it didn't suit their needs. They had varying opinions about the toolkit. PTs who reported using one or both tests before the study continued using them. Others who used none or one of the tests, they committed to using them in future with high-functioning patients. And the final scenario was more positive. In this scenario, professional leaders on or off-site were on or off-site. There were a variety of contextual barriers, but they were overcome. The professional leader had a central role in organizing the sessions. Despite challenges, They were able to set up walkways near the stroke unit, and the app facilitated use of reference values. The physical therapist used walk tests during the study to validate treatment, to educate patients and set goals, and most of the therapists expressed their intent to use the walk tests in future. So just to summarize, so we have some time for questions. In summary, the findings suggest that the physical therapists did increase their use of the 10-meter walk test and the 6-minute walk test to a lesser degree pre to post-intervention, and that also they used reference values after receiving the toolkit, possibly related to developing a high self-efficacy for these practices. The toolkit, the ability to mark walkways near a treatment area, the perceived relevance of the walk tests in ambulatory patients, and familiarity with the tests and professional leadership were primary enablers of walk test use. Learning session agendas, instructions for walkway setup, and equipment checklist in the iWalk guide helped professional leaders to prepare for and run the learning sessions. And the ability to quickly compare test performance to reference values in the app at the point of care facilitated patient education and goal setting. The 6-minute walk test was less likely than the 10-meter walk test to be used because of the time it took to administer and the perceived inappropriateness of the test for patients who could not walk 6 minutes continuously, despite the allowance of the protocol in the protocol for patients to rest and receive assistance to walk. So what I'm saying here is that, as shown in the realist evaluation, therapists tended to only use the 6-minute walk test in patients who were high functioning, in patients who they thought could actually finish the entire test without taking a break, even though the protocol says you can allow the patients to take a rest during the test. The fact that the 6-minute walk test requires the 6-minute walk test protocol, if it could be conducted on a shorter walkway, this might help therapists overcome the barriers to implementing it in hospital settings. And then in terms of limitations, this was an uncontrolled study design, so it's possible that some therapists were administering tests but not charting the results at baseline, and that they documented tests more consistently post-intervention. But we can't know to what extent because we didn't have control sites that didn't receive the intervention. And then with the feedback we received on the app, we received some funding from the Canadian Partnership for Stroke Recovery to improve the toolkit before we launched it last September on our website and the app in the App Store and Google Play. So I'd just like to acknowledge all the wonderful people who worked with me on this study, particularly Marilyn McKay-Lyons, who headed up the Halifax site, and all of our co-investigators who facilitated the study at our various sites. And then thanks to KT Canada for hosting this seminar series, and just to acknowledge the funding that we received for this study and for personnel awards that I've received. So thank you very much. I'd be happy to take questions. Sorry, Megan, but I can't hear you. Hi there, I'm just unmuting everyone.
because for some reason I'm muted.
I can hear you now.
But anyway, if everyone could try and mute themselves. Dr. Salbach, if you can hear me.
I can hear you.
We're just going to put the questions via the chat box.
No, c'est sûr.
And then you can just respond that way. Is that okay?
Yeah, I'm just trying to see the chat box because for some reason it's not. Because maybe I'll stop sharing my screen.
That's perfect.
Un des lundis fonctionnerait bien. So hopefully you can still hear me, everybody, but I can't see the chat box to see what people are writing. I can see the chat, but I don't see people. I don't see the questions there.
So there should be one to you from Nova Scotia. Do you see that? They chatted it to everyone.
So maybe you could just repeat the question, Megan.
Sure. Sorry, there's some background noise, but I'll mute everyone again after I read the question. So from Nova Scotia, they said in the qualitative interviews and focus groups, did they say if a culture of risk aversion impacted the use of the walk test? Did you get that?
Qu'est-ce qui était mieux, 9h30?
Yes, thank you. So the question about did therapists feel that there were, or were there were they worried about risks in performing the walk test? And what I would say is that they didn't describe that there were concerns about risk. There was this belief that they should only do the walk test in people who were high functioning and who could tolerate the tests in other words, that could tolerate walking for 6 minutes continuously. And so basically they conducted the tests more commonly in people in whom it was easiest, and this was mainly in the acute care setting. Now, our walk test protocol actually allowed the evaluator to provide assistance. So there wasn't that risk that people were going to fall because we had adapted a protocol from protocols that had been evaluated in the literature that allowed the evaluator to actually put hands on the person while they walked. And as long as this didn't require advancing the leg forward, that was considered acceptable to do the walk test.
Okay, thank you. We have another question. Angela asked, what was it like to work with app developers, and do you have any practical tips for researchers?
Okay, that's a great question. It was actually quite challenging, mainly because the app developers had their own vocabulary, had a different way of talking that I wasn't familiar with. So it was more like, and they didn't understand, my terminology necessarily. I think it was more the other way around, primarily, however, where I had to learn what was the usual process for developing an app. I didn't even know what the term beta testing meant when I started this. I also had a very clear view in my mind of what I wanted the app to look like. Whereas the app developers were interested in kind of observing clinical practice and developing the app themselves. But I really knew what I wanted, so we had to come to a mutual understanding there because, like I knew I wanted the font size to be accessible, that physical therapists wouldn't have to squint and, to read what was in the app. So it really was I think that the initial phase was a get to know you, and then also what was part of the process was I did meet a knowledge translation broker that facilitated this, but the whole process started off with with inviting 4 different companies to make a pitch to me about how they would approach developing the app and what their ideas would be. And then I selected the one company that I felt both had a good pitch and also that gave me a cost estimate that was appropriate, and then move forward there. In terms of tips, I would say that that it's really important to work with an app developer who understands the speed of research, because in a research study, you may have to slow down because you're waiting on reviewers' comments, for example, and that the development of the app may be iterative and it may happen and take longer than they expect. So they have to know that you might be in this relationship for a while, and that's just the nature of research. And so I would say that that's an important tip, and also that it's really important up front to be very clear about the creative license. So what is it that you want the app developer to do versus if you already come in with preconceived ideas, then you may want them to really just operationalize your ideas.
Okay, can you hear me now?
Yes.
Okay, perfect. I figured out what I was doing wrong, so I apologize for that. Okay, so another question from Nova Scotia. They said, sorry if they missed this earlier, but what type of background information did you use to know how to make a useful toolkit? For example, what types of KT strategies and tools to include in it?
So the background information that I used came from understanding that what the barriers were, and then what was the reasonable intervention to address that barrier. So we had done our homework, we'd done the foundational research and looked to the research of others to know that there were knowledge issues, so we needed some kind of education. So of course we needed some kind of educational guide. We knew that people weren't familiar with doing the test, so they needed a chance to develop skill. So self-efficacy theory tells me that it means I need them to practice. So I needed the intervention to involve, that needed to involve an opportunity to practice. I had done research looking at the use of an app, and I knew that there were some concerns, for example, about the size of the screen. So that led me to produce an app where I tried to make sure that it was easy to read, that the font size was large enough. And then also a facilitator from my qualitative research had been that people did appreciate if like manual calculations could be expedited in an app where they didn't have to take out a calculator. So I knew the app was an excellent solution for doing time extensive calculations that the therapist would normally have to do, that it could save them time. So it was really tailored. It was like really understanding the barriers and then understanding the context of stroke rehabilitation and that time-pressed environment, and coming up with these 3 sessions. I thought, okay, if you just do 3 lunch and learns, then that must be feasible. And that came from, you know, knowledge as a physical therapist. I mean, a lot of sites did not do this necessarily during lunch because lunchtime maybe should be protected time, but I felt like that at minimum that conducting 3 one-hour learning sessions should be feasible to implement.
Okay, thank you very much. We're just about at 1, so I think I will facilitate the final question. We'll do that over email. But thank you so much, everyone, for attending, and thank you so much, Dr. Salbach, for your presentation. And I just want to remind people to please complete an evaluation. There are some, in the email you received, there's a link to an online evaluation, and I will resend that. And I'd like to also remind everyone that on November 14th, that is our next KT seminar series with Dr. David Johnson from Alberta. And he's presenting on the creation of his data analyst team, My Child Alberta, to facilitate the evaluation of KT and quality projects. So thank you again, Dr. Salbach. We really appreciate you presenting with us.
Thanks, everybody.
Have a great day.
Bye.